Our next speaker is Dr. Raghuvi Dendi, and he's going to be talking about cardiac autonomic disorders.
I just did that to wake up everybody, and I just remembered something I read in ancient Sanskrit long time ago. So it's just drum beats announcing somebody's arrival. So the topic given to me was specifically intended for those of you who are used to getting postprandial anesthesia, can go to sleep. This is specifically timed exactly so that you can go to sleep and wake up for the next speaker. I'll try to be as smooth as possible. Okay, let's talk. Today, my topic is very wide-reaching and somewhat complex, somewhat less understood. And I would like to focus on salient features of three major components of autonomic disorders: neurocardiogenic syncope, postural orthostatic tachycardia syndrome, as well as inappropriate sinus tachycardia, as much as the time can permit. And we'll discuss some cases if time permits. Question: how long does it take to lose consciousness if your heart stops? Most people might have guessed it right. It's about 6.8 seconds. It was actually apparently tested at some point. So syncope is in Greek to interrupt consciousness. It's defined as sudden transient loss of consciousness and postural tone with spontaneous recovery. Loss of consciousness occurs within 10 seconds of hypoperfusion of the reticular activating system in the midbrain. And the maintenance of postural normal blood pressure is primarily by translocation of about 30% of central blood volume to dependent areas being brought back, so the brain perfusion is not affected. The compensatory responses that are involved in maintaining the perfusion are the muscle pump, the neurovascular compensation, humoral compensation, and the local vascular mechanisms. The action of the musculovenous pump in lowering venous pressure in the leg is very important and demonstrated here in the foot vein pressure measurement on y-axis and time with standing and walking, where a normal limb, the foot vein pressure drops and it compensates back to normalcy, whereas the limb with incompetent venous valves may not do that. The maintenance of postural normotension, as mentioned, is done by neurovascular compensation by high-pressure mechanoreceptors and low-pressure mechanoreceptors. The afferent trigger could be pain, being upset, dehydration via vagal C fibers. And the efferent response is initiated through sudden withdrawal of sympathetic neuronal outflows, reflex increases in plasma, epinephrine, vasodepression, that's resulting from the above two. And then in parasympathetic outflows may precede the vasodepression. That's responsible for the nausea, sweating, and bradycardia in the prodrome. So the definition of syncope could be varied, but in general, it's agreed that it's transient loss of consciousness with spontaneous recovery, which does not require defibrillation. Can be called blackout, faint, spell, collapse from the patient point of view. Patient is generally not responsive for the transient period of the time with quick recovery. It's not the same as coma, cardiac arrest, drowsiness, or generalized seizures. Pre-syncope, on the other hand, is a sensation of impending loss of consciousness without progressing to loss of consciousness. This may progress to loss of consciousness, in which case it's called a prodrome. Dizzy, being lightheaded, faint, disoriented, unsteady are the symptoms described by the patients. Just a few slides on diagnosis and evaluation options. This can itself be a separate talk, but I don't want to belabor it. The most likely test to determine a diagnosis in this case is history. And again, very important, more than anything else. And the differential diagnosis, a brief slide on seizures versus hypotension. Generally, seizures are sudden. Inadequate perfusion causes more gradual prodrome, followed by lack of consciousness, but that can be different. Duration is minutes for seizures, seconds for the loss of consciousness with syncope or inadequate perfusion. Jerking movements are frequent in seizures, rare in syncope. You could, in extreme cases, certainly get seizure-like movements. Headaches are more frequent after a seizure. Occasional can occur before a syncope. Confusion is frequent after seizure, rare after syncope. Incontinence is frequent in seizure disorder, rare in syncope. And eye deviation, tongue biting are more likely in seizure. And last but not the least, prodrome of aura before epileptic or seizure disorders, whereas dizziness is more common in, as a prodrome to syncope. This is an old slide most of you must have seen. Basically reiterates the stress in diagnosing the tools that are used for diagnosing syncope or other autonomic disorders include primarily history and physical, and the validity of most of the other tools is very questionable, except maybe in some arrhythmias you might rule out arrhythmia as a cause of syncope in using event monitors. The epidemiology, everybody knows it's very common, 40 to 50% lifetime prevalence, so 50% chance that everyone in this room might have syncope at some point. 0.5 to 1% incidence, 3 to 6% ER visits, 1% of hospital admissions. Cost is prohibitive. It could be up to $25,000 per episode based on the admission and workup that's done. Falls, disability, lost productivity, more costs added to it. The causes of syncope and relative frequencies in about 1,000 patients reported in Mayo Clinic proceedings. On average, divided into cardiovascular causes, non-cardiovascular causes, cerebrovascular diseases, and others. And as you can see, neurocardiogenic syncope accounted for about 48%. 48, yes. Vasovagal being most common. General treatment and lifestyle measures for neurocardiogenic syncope patients. Again, very important to stress on fluids. More, of course, depending on how much ambient loss of fluids they have in winter versus summer. Salt-loading fluids, food and supplements, especially if they don't have hypertension. Trigger aversion is a very effective technique if they can identify the triggers that potentially put them at risk for causing syncope. It cannot be avoided all the time, but certainly if you're conscious about it, you can get to a place before you pass out. Counter-pressure maneuvers and orthostatic training exercises. There are a set of exercises that they can follow to improve the so-called musculovenous pump tone and to reduce the drop in the blood pressure, especially in the vasodepressor type of patients with increased muscular tone in the lower half of the body. Water doping is just a fancy term for a quick grab of Gatorade or water when you're feeling lightheaded or dizzy or having a prodrome might itself raise your blood pressure by, on average, 5 to 10 millimeters of mercury. Drug therapy, fluorine has been studied, generally known to be useful in people who are less than 40, BP either normal or low. There's mixed evidence, especially when fluid and salt intake are not adequate, then it's a lot more useful. Midodrine, on the other hand, can decrease syncope and presyncopal spells in these patients. Beta blockers have been extensively studied. Not very useful for a post-trial, which was more recent, except when somebody is older, greater than age 40, with BP normal or high. It may be useful in that subgroup of patients. SSRIs, paroxetine has been studied and was found to be useful in only one single randomized controlled trial, but not the others. Pacemaker, almost never useful. There's some recent studies that suggest pacemakers with a CLS capability, closed loop stimulation capability, might be effective in severe cardio inhibitory syncope with greater than 3 seconds pauses on the tilt table test. So let's talk about PARTS. And what is PARTS? A lot of people ask me about it, and I have to explain. Postural orthostatic tachycardia syndrome. The definition for PARTS is orthostatic symptoms in the presence of demonstrable, exaggerated, persistent postural sinus tachycardia within 10 minutes of upright tilting in the absence of hypotension, less than 20 systolic or 10 diastolic fall in blood pressure. And so the key is maintaining the blood pressure while the heart rate goes up with significant symptoms. And increasing the heart rate of at least 30 beats per minute with standing, or heart rate greater than 120 beats per minute on standing. Demographics, it affects an estimated 500,000 Americans. Female to male ratio is quite high, at least 4:1. Age usually less than 35 years. Orthostatic intolerance is the other name, also most frequently encountered dysautonomia. Significant toll on lifestyle and work capacity. Presentation typically in the form of lightheadedness, palpitations, and tremulousness during standing, visual changes, discomfort in the head or neck, throbbing of the head, poor concentration, tiredness, weakness, and occasionally fainting. So PARTS doesn't mean they don't faint, they can still faint. Bluish red suffusion of skin in lower extremities on standing, which are relieved by lying down, sometimes accompanied by chronic fatigue syndrome. Similar orthostatic picture can occur in other situations like serious debilitating illness, substantial weight loss, and deconditioning, or after space flight. Etiology is unknown. It's generally predated by a recent viral infection. That's an important clue in the history. There is a heterogeneity of disease states, and there are many names given to this condition. Overlap with other conditions such as chronic fatigue syndrome, neurally mediated syncope, and physical deconditioning, etc. Pathophysiology is complex, but somewhat being understood. Normal or slightly increased supine baseline heart rate. Blood volume, interestingly, is usually reduced by at least 5 to 25% in these patients. Plasma norepinephrine levels are normal, high normal, or raised. Final common pathway is thought to be abnormally enhanced sympathetic drive of the cardiovascular system in the form of cardiac beta-adrenergic hypersensitivity. That's one form of PARTS. Partial autonomic neuropathy, which is more common form of PARTS. And generally, most people have excessive venous pooling, gravity-dependent fluid shifts, diminished plasma volume or red cell mass, diminished cardiovagal baroreflex sensitivity, brainstem dysfunction, or enhanced baseline sympathetic activity. Again, as mentioned, there are two forms of PARTS recognized. One is the central beta hypersensitivity form with high catecholamine levels and a norepinephrine transporter deficiency that can be actually tested. That's less common. The majority of patients are partial dysautonomic form. It's centrally mediated with some peripheral effects. Again, as mentioned, pathophysiology is partial. The common one is could be an autoimmune mechanism where there's an antibody against alpha-3 subunit of nicotinic receptor on autonomic ganglia. Cyclical changes due to estrogen-dependent change of the plasma volume can contribute to this condition. And again, in a small subselected patient population, they can have norepinephrine transporter deficiency that can lead to the problem. Very interesting and important question between PARTS versus syncope. We looked at a bunch of patients and saw clinically what kind of things differentiate them. Let's see if I don't have. So the things that you can see here that are significant. Orthostatic intolerance is a little bit more common in PARTS patients, whereas syncope patients, in general, they're normal between the episodes, whereas PARTS patients always have orthostatic intolerance. The pre-syncope is a little bit more common in neurocardiogenic syncope patients. Again, actual evidence of syncope, understandably more common in neurocardiogenic syncope, but not entirely eliminated in PARTS patients. Tilt-induced tachycardia, 16 out of 16 patients here in PARTS, 0 out of 18 by definition in syncope. And then tilt-induced syncope, again, you can have, if you tilt them long enough, PARTS patients will faint. And syncope, of course, it's common. Florinef response is more commonly noted in PARTS patients, but not in syncope patients. This is one study that looked at cardiac sympathetic dysautonomia in chronic orthostatic intolerance syndromes when we were at NIH looking at various indices on these patients. We found that they do differ in tonic cardiac sympathetic function, increased cardiac norepinephrine release noted in PARTS patients, and decreased release in neurocardiogenic syncope patients. Both groups had normal values for indices of function of the cell membrane, norepinephrine transporter, norepinephrine synthesis, and density of the myocardial sympathetic nerve terminals, which we studied using PET scanning. So one needs to understand that these are, even though these are somewhat discrete conditions, they could be overlapping syndromes with common features. And this is a nice figure that demonstrates the commonality between chronic orthostatic intolerance in the form of PARTS with inappropriate sinus tachycardia, chronic fatigue syndrome, and even neurocardiogenic syncope. The outlook in PARTS patients, in majority, it's a mild disorder which improves over succeeding weeks and months. So that's reassuring. More than half of the patients remain on treatment. Better prognosis, especially if they have an antecedent viral infection that triggers this condition. If they have spontaneous onset, it sounds like the course lasts a lot longer. This is a study looking at if sinus node modification is appropriate for patients who have both inappropriate sinus tachycardia and PARTS together. And the conclusion from this study was that sinus node modification is not recommended in this patient population. This is a New England Journal study that's looking at neuropathic postural tachycardia syndrome, where they felt, based on the study, that the neuropathic postural tachycardia, also other name for PARTS, results from partial sympathetic denervation, especially in the legs. How did they come up with that conclusion? They took 10 patients with 8 normal subjects as control. They measured norepinephrine spillover, the rate of entry of norepinephrine into the venous circulation, into the arms and legs, both before and in response to exposure to 3 stimuli, the cold pressure test, sodium nitroprusside infusion, and tyramine infusion. And they found that at baseline, the norepinephrine concentration in the femoral vein was lower in patients with PARTS than in normal subjects. And the spillover in arms increased to a similar extent with the stress or the 3 stimuli, but the increases in legs were smaller in patients with PARTS than in normal subjects. This is another study looking at effect of saline infusion in people with PARTS to treat underlying hypovolemia. And they found that they do respond well. So saline infusions acutely can improve symptoms. And chronically, on a long-term basis, salt and water intake in conjunction with Florinef seems to help. And patients do respond to alpha-1 agonist midodrine, especially to raise the blood pressure. So therapy for PARTS patients, orthostatic exercises, water, again, to be reinforced, salt up to 10 to 15 grams daily. But really, it depends. More recent studies showed that if their urinary 24-hour sodium is less than 124 millimoles, then it's more likely to benefit if you increase salt and water. Whereas if they already have enough sodium coming out, then that may not add additional benefit. Low-dose beta blockade, there's some data benefit. Alpha-2 agonist, no benefit. Midodrine has more data. Epogen may be helpful, especially in low RBC mass. I can't. So you need to find the right solution for the right problem. Inappropriate sinus tachycardia, just a few slides. The definition is inappropriate sinus tachycardia was defined as a heart rate greater than 100 beats per minute at rest or with minimal exertion, with P waves during tachycardia that were identical or very similar to P waves during sinus rhythm, with no other identifiable causes for sinus tachycardia such as hyperthyroidism or orthostatic hypotension. So important to differentiate between POTS and inappropriate sinus tachycardia. There is the heart rate is inappropriate for physiological need all the time, most of it for these people, whereas POTS, it's with orthostasis. Its symptoms are frequently multi-system in inappropriate sinus tachycardia patients and as well as POTS patients. And the proposed mechanisms are slightly different. How about catheter ablation in just inappropriate sinus tachycardia patients, guided by activation mapping? I don't have that slide, but the bottom line for ablation in inappropriate sinus tachycardia patients is beneficial in a limited number of patients, primarily because the way when you modify the sinus node, either it can result in abrupt drop in the heart rate, or it can be a decremental drop in the heart rate, and the symptoms may stay the same even though you achieved the heart rate response. So technically, objectively, you met the criteria, but the autonomic central mechanisms are still in play, and the patients may still feel terrible. So you have to really carefully select those patients. Management of inappropriate sinus tachycardia, beta blockers can be tried, especially non-selective beta blockers might be helpful. Calcium channel blockers, not that useful. There's a new drug called ivabradine, which is available in Europe, but not here. It inhibits funny current, or IF channels, and specifically has effects on sinus node, has less side effects than beta blockers, and probably more effective, especially with exercise. And again, sinus node modification, some benefit. I think I'll summarize my talk with saying that neurocardiogenic syncope, POTS, and inappropriate sinus tachycardia are clinically distinct, yet overlapping syndromes of autonomic dysfunction. Careful history and selective testing will help guide diagnosis and management. Patient information and aggressive lifestyle changes are primary mode of treatment. Drugs, ablation, and devices are supplementary or complementary with limited benefit. More knowledge is needed, and the time spent with patients, informing them and enlightening them about their condition, reassuring them, is more valuable than a number of tests we do for these patients. Thank you.